Hello, and welcome to the special National MS Education and Awareness Month conference hosted by MS Focus, the Multiple Sclerosis Foundation. This is made possible with the support of Genentech, Bristol Myers Squibb, Sanofi Genzyme, Biogen, EMD Serono, Novartis, and Viatris. This presentation has additional support from Ocrevus. I'm your host, Chris Hudspeth, MS Focus Radio Manager, and today we are joined by Dr. Ben Thrower, who will be speaking with us about MS and your health. After the presentation, we'll open it up for questions and comments. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, Georgia. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. And Dr. Thrower is a senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to our quarterly MS Focus magazine. When Dr. Thrower isn't dressing up as the pirate Jack Sparrow, he can be found playing with his new grandson named Sam. We're pleased to have him join us to present this important topic. And thank you, Dr. Thrower. We'll turn it over to you.
Great. Thank you, Chris, for that very kind introduction. And thank you to all of the other staff at MS Focus. We really appreciate all that you do. Thank you to the sponsors for allowing us to put programs like this together. And thank you to everyone who's joining us this afternoon. We appreciate you taking the time. So as we were putting this together, the MS Focus folks and I were discussing the topic. It's pretty broad. We could have gone a lot of different places with this. So I wanted to just kind of throw out a range of health topics, and then we'll leave plenty of time for discussion afterwards. So first slide, Chris. So this seems like a silly question, but can a person with MS be healthy? So does having a chronic health condition like multiple sclerosis mean that you can't be healthy? Next slide. You know, the obvious answer is, of course, you can be healthy. So, you know, it was taught to us in medical school that everyone is pre-symptomatic for something. We're all going to have a health condition at some point, you know, of some variety. So that doesn't mean that you're not a healthy person. And I would say that when we think about health, that's a very broad topic, and we kind of put it into the bigger picture of wellness. A lot of things go into being well. Your mental well-being, your physical well-being, your financial well-being, your family support, your friend support. There's just so many different things that contribute to that. But we're going to focus mainly on some physical sort of things that contribute to wellness and touch a little bit on mental health. And I know that through the MS Focus, we've done some other discussions this month on mental health. So I'll try to add a little bit to that. Next slide. So one of the important things to remember, and many of you on the line probably know this, if anyone's newer, maybe you don't realize this, but people don't typically die from multiple sclerosis. People with MS tend to die of the same things that everyone else dies from typically. That's going to be heart disease, cancer, and stroke. If you were a strict actuarial insurance kind of person, you could say, well, the life expectancy for a person with MS technically is 7 years shorter. But that's a little bit misleading. What that may represent is a very small group of people who have very aggressive MS, who have a lot of complications early on, who may end up getting skin breakdown or a pneumonia or a urinary tract infection with sepsis. And that very small group may pull the numbers down for the rest of everyone else. But typically, people with MS have a normal life expectancy. And given that people with MS tend to die of cancer, stroke, heart disease, we probably should put our wellness discussion into that bigger picture. Next slide. So one of the scourges for all of us for our health and well-being is obesity. And so this is a snapshot of the United States going from 1990 to 2000 to 2010. I'm sure if we went to 2021, our map of America is going to look more and more red. These are the rates of obesity, and they counted a BMI of over 30 as being obese. BMI has its limitations, obviously. So if you take an NFL running back who has a body fat percentage of 6%, but who's mainly muscle, but the guy weighs 240 pounds, he's going to probably have a BMI over 30. So it doesn't take into account body composition, but for most of us, it's a pretty good gauge of where we're at in terms of our body fat percentage. So we would like to see generally BMIs of under 30. And we are, unfortunately, as a country, getting bigger. If you go back and watch, old, TV series from the 1960s and 1970s, we looked different as a nation. We were smaller, we were thinner then. Next slide. So the term diabesity, kind of putting adult onset diabetes and obesity together, has been coined, and part of that is because as a human species, we're this modern, very food available era that we're living in really is a relatively new thing. As a species, we were sort of, we evolved to be very good at holding on to calories because calories really weren't always available. You think about our hunter-gatherer ancestors who may not have eaten, but maybe once every few days. Our bodies had to be very good at holding on to calories. If you look at certain races, like indigenous people in the Americas, they are very, very good at holding on to calories. And as we've moved into a society where food, sometimes not very healthy food, is readily available, so, some of our indigenous people who are genetically so good at holding on to calories are really paying a price because they have very high rates of hypertension and diabetes. So we are seeing a lot of adult onset diabetes in the United States and really in most of the developed world because our food availability has really outpaced our genetic evolution. We're still very efficient at holding on to calories as humans. Next slide. So if you look at the United States versus other European countries, so in the past 30 years, fat intake in the United States has gone from 119 grams per day to 155 grams per day. Compare that to France, where the average guy is taking in only 94 grams of fat per day and average woman 73 grams per fat per day. The French have this reputation for eating these incredibly, rich foods and lots of butter, but in reality, their fat intake is actually just a fraction of what ours is in the United States. And correspondingly, their obesity rates are lower as well. Next slide. So how does this then tie into multiple sclerosis? Is there any impact of obesity or higher BMIs on multiple sclerosis? And it turns out there is. If you look at people with a higher BMI in their teen years, that is one of many, many environmental risk factors that could put you at higher risk for developing MS. It's especially true in teenage girls who have higher BMI. Some studies have suggested that obesity in people with multiple sclerosis is also associated with more disability. You can say associated, but you can't necessarily say cause. So is it that as people have more physical challenges and limitations in their mobility, are they more likely to become sedentary and gain weight? Or is the weight itself contributing to maybe more inflammation and leading to more disability? I don't think we have all of that worked out, but there clearly is an association. Next slide. So what do we do about this? I think one of the most common questions we hear in our MS center is, what's the best diet for a person with MS? And the honest answer is, we don't know what the best diet is if you're talking about a diet with a name on it. So should people be following the Walls protocol? Should they be doing the Swank diet? Should they be doing a paleo or a Whole30, a keto diet? What is the best for people with MS? I think that we can all agree on some trends, though. So while we might not agree on what the specific named diet we would recommend, we do think that in general, Americans, we do get too many saturated fats. So we would like to limit saturated fats. We would like to increase our omega-3 fatty acids, things like you find in fish, cold water fish specifically, decrease our carbohydrates, Try to avoid processed foods and high sodium foods. High salt diets have been linked to a higher risk of multiple sclerosis. Eat more fruits and vegetables. Do what our moms told us to do when we were kids. Try to focus on healthy fats, things like avocados, olive oils, Mediterranean diet type fats. Of all the vitamins that have been looked at in multiple sclerosis, where the strongest evidence is at is with vitamin D. So I do feel very strongly that people with MS, and probably everybody for that matter, probably needs to have their vitamin D levels checked. It's been estimated that about 40 to 50% of the general public is vitamin D deficient. And when you look specifically at the MS community, it goes up to about 85% of the MS community. A number of the genes that put people at risk for multiple sclerosis and probably other autoimmune conditions as well have to do with vitamin D metabolism. So we see a lot of people with MS that seem to be doing all the right things. They have a decent diet, they're getting some sunlight, and their vitamin D levels are still just incredibly low. And that may be because the genes are stacked against them, and we're just going to have to do some supplementation to get those vitamin D levels up into a good range. We've probably mentioned this before, but vitamin D is a fat-soluble vitamin. So A, D, E, and K are your fat-soluble vitamins. Your fat-soluble vitamins are the ones that you can't just randomly mega dose on. So unlike vitamin C that you could probably take a bucket full and not hurt yourself, vitamin D and the other fat-soluble vitamins, you want to have your blood tested to know where you're at before you start dosing, because they can be harmful at higher levels. If you have vitamin D levels that run too high for too long, you actually are at risk for what we call ectopic calcification. You start depositing calcium in places that you don't want to put it. And one of the more common areas would be in the kidneys. So high vitamin D levels over long periods of time can be associated with kidney stones, which will definitely ruin your day. Interesting research out there on intermittent fasting. So skipping a meal or skipping 2 meals or maybe skipping a whole day's worth of meals appears to be associated with better weight maintenance and maybe less inflammation. Before you look at intermittent fasting as a possible dietary sort of lifestyle, I would certainly talk to your physician. If you have diabetes, if you have hypoglycemia, there might be reasons medically why you don't want to skip meals. So shifting from just the diet piece, the other way that we burn calories and maintain health is through exercise. And one of the most common questions we get along with the diet question is, what's the best form of exercise for a person with MS? And there's no one set answer. I would say the best form of exercise is the one that you'll stick with. If I send you to a physical therapist or an exercise physiologist and they set you up with an exercise program that's not very accessible to you, or maybe you just hate it. So let's say we put you in an aquatics program and you just don't like being in the water. You're probably not going to stick with it. So, as you're thinking about your exercise program, or if someone's helping you design an exercise program, be honest with them. Tell them what you have access to. Tell them what you like and don't like. Next slide. So we've evolved quite a bit over the years. So if you were working with the MS community in the 1960s and 70s, we were at the bottom part of this slide. We told people with MS, do not exercise. Exercise is bad for you. You have fatigue. You're going to use up what little energy you have with exercise. And we could not have been more wrong. So we move up the timeline to now thinking exercise is okay for MS. If any of you have not heard the Jimmy Hugo story, he was a person with MS who really pushed us up this ladder from thinking that exercise is bad to exercise is okay to exercise is good. Jimmy Hugo was the youngest American ever on a downhill ski team. The U.S. men had never won a medal in anything in alpine skiing, and in 1964, Jimmy Hugo won the bronze in the giant slalom. Another American, Billy Kidd, won the silver. They were the first American men to ever medal in downhill skiing. Jimmy had already had his first MS attack at that time. He didn't know that he had MS, but shortly after those Olympic Games, he was diagnosed. People with MS, again, in the 60s were told don't exercise. So imagine being an Olympic athlete, you've trained your whole life, and now someone says, it's all over, don't exercise, go sit on the couch, have a nice life. He was not accepting of that. So he went out, started exercising more, felt better, put his money where his mouth is, started doing a lot of fundraising for exercise research in MS, and again, taught us that exercise is okay and it's actually good for MS. Next slide. So we do quite a bit of exercise research here at Shepherd Center. And one of the things that we've learned is this kind of bucket of disability model. So if you think about the challenges, the physical challenges that you might face as a person living with MS, so what is in that bucket? What are the ingredients in that bucket? Well, there's damage in the brain and spinal cord, the central nervous system. There's demyelination. The coating of the axons has been stripped away. There's actual axonal transection. We're learning now that there's also damage in parts of the brain that we really didn't appreciate, in the deep gray matter and cortical gray structures. So those are fixed areas of damage. We as humans do have the capacity to do some repair of the central nervous system. Obviously, we'd like to see therapies in the future that actually promote more of that repair. But until we get to that point, let's imagine, for the sake of argument, that damage in the central nervous system is there. We can't change that ingredient. The second part of that bucket of disability is deconditioning, and we can change that. Next slide. So if we attack your deconditioning, we're going to make your bucket of disability smaller. Have we repaired anything in the brain or spinal cord? Probably not. But we've improved your level of functioning, and we've made that bucket smaller. Next slide. So these are some of the studies that we've done over the years at Shepherd in exercise. And one of the things that we've really tried to focus on is not just how does the able-bodied person, maintain daily exercise, but how does the person with physical challenges exercise? How does a person with progressive MS who's in a power chair or scooter or using some other sort of assistive device, how do they access good exercise programs that are going to be beneficial to them? And so some of the things we've learned over time is that with regular exercise, people with MS, regardless of level of ability, do see improvements in their impairments. With range of motion, with stretching, we see improved range of motion, we see improved strength, better endurance, decreased fatigue, and decreased pain. Next slide. This is kind of a similar idea, but we see improvements in disability. And again, this is just through reconditioning. To the best of our knowledge, we don't think that we're causing repair in the central nervous system, although that may be a little debatable. Maybe we're promoting neuroplasticity, or if you will, rerouting around areas of old damage. So we see improvements with bed mobility, with transfers, with ambulation, and probably most importantly, all of these translate into improvements in activities of daily living. Next slide. Quality of life. There are all kinds of surveys that we can do to give to people in the MS community that measure quality of life. One of the things we see in improvement in is emotional stability. People feel better. Their anger is reduced. One of the things we've definitely noticed with our wellness program is there's so much social interaction and participation. We have people coming in and spending the day at the exercise facility. Well, then they end up going to lunch together. They end up making friendships. We've set up a concept of exercise buddies. We know if someone's supposed to go to the gym and exercise, if it's just on their own volition that they're supposed to go, maybe they're having a bad day and they don't feel like going. If their exercise buddy is counting on them to be there and waiting there for them, there's much more likely that person's going to show up and stick with their program. One of the things I'm very proud of, and a lot of MS centers have this, are just therapeutic recreation programs. Exercise is not all just about going to the gymnasium. It's about having fun. So we have all kinds of water ski programs, snow ski programs, fencing, wheelchair rugby, you name it, just any number of sports to just make it fun. And then again, what we've seen with the quality of life is just all of that translating into doing better at home and with your activities of daily living. Next slide. Physical health measures. So these get more kind of objective measures, things like better breathing capacity or oxygen saturation, decreasing your body fat, and improving your blood lipids. We know that as you exercise, some people will actually drop their total cholesterol. Some people don't drop their total cholesterol, but they change the ratio. They raise the levels of HDL, the good cholesterols, that start going up. And that, even without lowering your total cholesterol, is heart healthy. There is a suspicion that good cholesterol plays a role in inflammation. So it's more than just a cardiovascular issue. It might have a feedback in terms of less inflammation, which would obviously be beneficial in the setting of an autoimmune condition. Next slide. So in the big picture, we want you to really take care of yourself. There's a tendency, especially when someone is newly diagnosed with MS, to really make MS the focus of your health. And I think that's very normal. But at some point, we want MS to kind of take a back seat, and it needs to share the car of your life with other health issues. Just because you have MS doesn't mean you couldn't have other health problems. You could have thyroid problems or diabetes, any number of things. So we really want you to have a good primary care provider. Establish a good relationship. Technically, as important as MS is, that primary care provider should be kind of controlling everything else. Your other specialty referrals, we should be able, as your MS center, to send records to them and get records back from them. Some of the newer electronic medical records, as we start having shared systems, has made that a lot easier. I've always thought it was frustrating that for all the high-tech things we do in medicine, sometimes the weak link in our high-tech world was getting a piece of paper from point A to point B, from one healthcare provider to another healthcare provider. But at least some of these shared electronic medical records have made that a little bit easier. Make sure you're getting your routine health checkups, your mammogram, the pap smears for women, colonoscopies for both men and women at the age that your primary care doctor thinks is appropriate. Checks on prostate-specific antigen for guys, and get appropriate vaccinations. We've always known that things like influenza shots and shingles and pneumovax are important, but now we've got COVID to think about. Next slide. So we've learned an awful lot over the past year. It's hard to imagine that this whole COVID pandemic, really just started a year ago, a little over. And here we are now with 3 approved, or so emergency approval vaccines that we can talk about. And it seems like we've been just dealing with this for decades now. So the National MS Society in late January came out with their first statement on COVID vaccines for people with MS, and they just did an update about a week and a half ago to take into account the Johnson & Johnson vaccine. All 3 vaccines are felt to be safe for people with multiple sclerosis. Obviously, there are a lot of individual variations. If you've had a severe reaction to a vaccine in the past, talk to your team about whether for you the vaccine is safe and recommended. We do have to do a little bit of explaining sometimes with the Johnson & Johnson vaccine. So all 3 of these vaccines are messenger RNA vaccines. Messenger RNA is a blueprint for a protein, and in this case, this messenger RNA is a blueprint for the COVID spike protein. So your body is going to see that messenger RNA, it's going to produce that COVID spike protein. Your immune system is going to mistakenly think that you have a COVID infection and make an immune response to that spike protein. And now, hopefully in the future, if you're exposed to the COVID virus, your immune system is going to rise to the occasion and take care of that problem for you. Both the Moderna and Pfizer vaccines took their messenger RNA and coated it in a fatty lipid substance to get it into the system and get that messenger RNA where it needs to be. Johnson & Johnson used a virus. It's called a non-replicating adenovirus. It is a live virus, and traditionally we have told people with MS to be cautious about live virus vaccines. This is an exception. This vaccine was specifically selected so that humans would not react to it. It is just the carrier for the messenger RNA. So this is an exception that normal live virus rule. Moderna, Pfizer, 2-shot series, and the Johnson & Johnson is a 1-shot vaccine. Again, we're okay. I think right now, when people are showing up for vaccination, I don't know that we really have much choice or say in the matter. You're probably going to get what they have. There may be a time as supplies ramp up where you do have a choice, and honestly, I'd be okay with any of these. You might argue that the Moderna and Pfizer efficacy numbers look a little bit better than Johnson & Johnson, but if I showed up to be vaccinated and Johnson & Johnson is what they had, I certainly would be okay with it. If you're on a disease-modifying therapy, there may be some discussions about the timing of the vaccine with your medications. Talk to your MS healthcare team about that. There's pretty good agreement on a lot of the medications where things, you'll hear some discussion back and forth about timing is with drugs like Ocrevus and Rituxan. And again, there are a lot of different thoughts on how that works out timing-wise. Next slide. So, we've talked some about physical health. Don't forget your mental health. If you are suffering from depression or anxiety, everything else that you deal with your MS is magnified. And depression and anxiety are more common in multiple sclerosis. Some studies have suggested that the majority of people with MS will at some point during their life deal with depression or anxiety or both. The old thinking was that these were just normal human reactions to dealing with a long-term health problem. And sometimes that is the case, but it's also just part of the biology of multiple sclerosis. We see individuals with MS who are doing great. Their MS is well controlled, their life is good, job is great, home is great, everything's wonderful, but they're still dealing with depression or anxiety. And that may be part of just the biology of the structural changes in the brain, the immunologic changes that are going on as part of that MS process. Again, we said depression certainly makes other symptoms look worse. Sometimes people have used the analogy of a 3-legged stool when we're talking about depression, cognition, and energy levels or fatigue. And worsening of one leg of that stool is going to make the other 2 legs weaker, if you will. So if someone is having depression, their fatigue and cognition look worse. One of the common signs of depression is poor attention and concentration. And many people with MS will come in and say, my memory is just horrible. And when you start asking them more about that, they're describing very, very short-term issues. So a conversation that they had, maybe 5 minutes later, they can't remember details, or maybe they don't remember the conversation at all. They read something, and maybe by the time they get to the bottom of the page, they can't remember what was at the top of the page. Mm-hmm. That may be more of an attention and concentration issue than a true memory problem. So in that situation, the person is not storing information to recall it just a few minutes later. And both depression and fatigue will cause those attention and concentration problems. And in some ways, make the person with MS, make them look like they have ADD in some ways. Next slide. So depression and fatigue, they sometimes kind of meld together, if you will. So, how can you tell if you're tired or are you depressed? And realize they're not mutually exclusive. They can coexist, and one day you may deal with more of one than the other. There's a medical term, anhedonia. Anhedonia is a Greek term meaning a lack of hedonism. It means you have a lack of desire to do something that would normally be fun. So if you're trying to sort out whether you're on a given day suffering from a mood issue or an energy issue, let's say that there was a movie. I know it's a strange concept to think about going out to movies, but let's imagine we're pre-COVID or we're post-COVID now, and we're going to a movie theater, and it's something you've really looked forward to all week. And now come Friday afternoon, you're just not up for it. If you are frustrated about not having the energy to do it, you still desperately want to go, but you just are too tired to do it. That's probably lassitude or lack of energy. If it suddenly doesn't seem like much fun to you anymore, it just seems kind of blah, and you really don't care much about it, that may be more in the anhedonia camp. And trying to sort those out in your mind and with your support partners, helps us out in knowing which direction we're going to go in terms of how to help best deal with that symptom. Next slide. So ways that we deal with depression: exercise daily. I know especially if the person's dealing with fatigue, it's always felt kind of cruel to tell that person, I know you're really tired, but I want you to exercise now. But that is one of the ways that we push past both depression and fatigue. Try to reduce the stressors in your life as much as you can. I know it's tough. No one is stress-free. Breathing exercises, meditation are great ways to kind of recenter yourself and turn down the volume on the noise of the outside world. Maintain your social networks. Have your friends really, stay engaged with you. One of the things I challenge, if I see a person that's dealing with depression and they have anhedonia, they don't really want to go out and do much, I'll challenge their children, their support partners, their friends, drag them out of the house, get them outside, go to dinner, go for a walk, do something. The more isolated that person becomes, the more the world starts closing in on them. And it really perpetuates that cycle of depression and fatigue. Keep in touch with your medical team. Let us know what's going on so that we can help you out. Talk about your feelings, acknowledge them. There's sometimes this, I think, feeling in culture that depression is a sign of weakness, that if we admit to it, that we're somehow a failure. And that if we talk about taking a medication for it, that's really not a good route to go down. Think of depression in the same way you would think about weakness or foot drop. It's a manifestation of a problem in your central nervous system. It's just a different area of your central nervous system. Using an antidepressant or seeing a counselor is no different from seeing a physical therapist or using a disease-modifying therapy. We really need to take the stigma away from any sort of mood issues. Be careful with any sort of addictive substances or mood-altering substances. People can fall into a trap of self-medicating with alcohol or even cannabis. The cannabis, clearly, we do whole other lectures on that, can have beneficial properties in multiple sclerosis, but when it starts to be used as a psychological crutch or an escape from really what the real problem is, then it's become a problem and not a help for you. Next slide. And with that, I am going to stop talking and turn it over to you folks for questions or thoughts that you might have.
All right. Thank you. Thank you so much, Dr. Thrower. Let me get out the PowerPoint presentation here, and we will start to take questions. If you have a question or a comment, make sure you please raise your hand. It's a feature in the app, or to send your question via chat. To raise your hand, click the screen to pull up the menu, select more. It's the icon with the 3 dots, and then click raise hand. I'll unmute you, and then a prompt will appear on your screen asking to allow me to do that, and please select allow. So if anyone has any questions to get going, Casey, I know had sent me one for you from someone, and it was on vitamin D supplementation. When is it a good idea to be prescribed short-term high-dose vitamin D? For example, 50,000 units, or is it only for people who run below the lower unit in the normal range?
Yeah, great question. So there really is not a perfect vitamin D dose. It really depends upon what the level is. So it's not uncommon for people to be prescribed 50,000 units of vitamin D. Realize that if you have low vitamin D levels in a person with MS, they're probably going to need to be on some degree of vitamin D supplementation forever. The question is going to be how much vitamin D. So it's common sometimes for people to be prescribed 50,000 units weekly for 6 weeks, and then it stops. The problem with that, your levels are going to go up, but then they're going to come back down. So you want to make sure that someone's checking those levels continuously. We have a lot of people with MS who are on 50,000 units weekly forever. Again, you've got to follow the levels and see what happens. Do they come up and plateau and stay in that? Because sort of our desired range is a 25 hydroxy vitamin D level of between 50 and 80. If the person comes up to that, let's say they hit 60 and they plateau there, that's great. We'll leave them on 50,000 units weekly forever. Let's say that they're on 50,000 units weekly and they go 50, 60, 70, 80, 90. Well, then we need to back off. Maybe we go to 50,000 units every other week. The other thing that we try to take into account is what is most convenient for the person. So once weekly or every other week dosing sounds pretty convenient to me. It's also easy for people to forget. So just be honest with your team. If taking something once a week or every other week is just not going to work for you because you forget to do it, you can certainly then convert that over into a daily dose. It is important to know what you're being prescribed also. There's sometimes when a doctor or other healthcare provider writes a prescription for vitamin D, 50,000 units, they don't specify, and the pharmacy may give you D2. D2 is the plant version of vitamin D. It's ergocalciferol. Your body has to convert that to cholecalciferol, the animal version. It still works, but you lose a little bit in translation. So if you have a choice, you'd rather take the animal version, D3, or cholecalciferol right off the bat. There is an over-the-counter 50,000 unit vitamin D. It's a vitamin D3. For some people, depending upon your insurance, that may actually be cheaper than going through your insurance company and doing a prescription. That 50,000 unit D3 bottle has 100 tablets in it. If you're taking once weekly, that's going to last you for over 2 years, and it's about $28. So it's under $1 or just over $1 and change a month. So lots of different ways of doing the vitamin D, but that 50,000 unit is something that we certainly do. But most frequently for us, it's an over-the-counter version.
In addition to that, there was a little bit more, a couple other questions in there with, and this is from Lisa. She says she supplements with 3K a day, and her blood level consistently hovers around the lower limit normal range. She's curious if she should ask her doctor if she should take more.
So again, most of the MS trials have suggested is that 25 hydroxyvitamin D level of 50 to 70 seems to be the sweet spot. So if you're in that lower limit of normal, which in most labs is going to be in the low 30s, yeah, you'd like to get it up a little bit. So you typically, it wouldn't be of any harm to go from 3,000 to say 5,000. Run it by your doc and make sure that they're good with that there's no other reason you can't do it. But that would be what we would do in our setting. Or we might look at putting the person on the 50,000 unit once a week if they wanted to do just one pill per week. But yeah, you'd like to get it up around 50 to 70.
Okay, and then from our chat, Sandra asks, does exercise create new neural pathways in MS?
Yeah, so that's one of the $1 million questions. And so it's tempting to think so. It's difficult to prove it, but I will say there are a lot of researchers out there who do believe that's the case. We do know that exercise improves recovery after a neurological injury. So there was a study that looked at people after a pretty significant MS relapse. And in one group, they just treated the people with 3 days of IV Solu-Medrol, like we typically do. In the other group, they got 3 days of IV Solu-Medrol and aggressive rehabilitation. The rehabilitation in steroid group did much better than the steroid-only group. And the theory was that it may have been through neuroplasticity or promoting new pathways. So in my heart of heart, I do believe that's probably the case. I think it's a situation of use it or lose it. And the more we use things, probably the more we promote, neuroplasticity and sprouting of axons and better recovery overall.
Okay. From Judy, have you ever heard of a wellness technique that utilizes cranial electrical or magnetic stimulation for neuroplasticity?
Yeah, so there is some interest in that. So using magnetic fields to treat different neurological conditions is something that has been researched. It's been looked at for fatigue management, and there have been some positive studies. A device just got approval, FDA approval last week in multiple sclerosis called the Helios or PONS, P-O-N-S device. It is an electrical stimulation device that is felt to be what we call a neural modulator. I'll confess I've not seen the studies on that yet. We were looking at doing trials here. They started those studies originally in traumatic brain injury, and they wanted to see if they could improve outcomes in traumatic brain injury. It's a device that's worn in the mouth for limited periods of time, and it delivers a low-level electrical stimulus to the brainstem to promote healing. And so, again, it did get the sign-off from the FDA. We probably should do a whole program on that as we get more. Again, it just came off the press Friday afternoon of last week, to see if we can look at those studies and see kind of what the numbers look like. But yeah, there is research in both those areas, magnetic fields and neuromodulation through electrical stimulus.
Okay, from Lydia, does inflammation play as big of a role in primary progressive MS as it does in relapsing remitting?
Yeah, so primary progressive MS has always been the kind of the odd man out, if you will. So it's accounts for about 10% of the MS community. There aren't big relapses. We don't think that inflammation is as big of an issue in primary progressive MS. Most of our usual disease modifying therapies, our old copaxones and interferons just didn't work out in primary progressive MS. Ocrevus did get FDA approval for MS. I think the reason a lot of our disease modifying therapies haven't worked out is that there is less of an inflammatory target to shoot at. And at the end of the day, most of our disease modifying therapies are anti-inflammatory. So it may be with primary progressive MS that it is a little bit more of a neurodegenerative process than an inflammatory process. So it does make it a bit more of a challenge. That's not to say there's no inflammation, though. I still think it's worth having discussions in people with primary progressive MS about disease-modifying therapies like Ocrevus and hopefully more options in the future.
Okay, let's see. We have a question from Karen. Thoughts on taking vitamin B12? Should everyone take it?
So statistically, the MS community does have a little bit lower B12 levels. I would say everyone with MS, I would bet most people with MS have had their B12 levels checked as part of their initial diagnostic workup. That's usually kind of standard to check that if people come in with new neurological symptoms and MS is part of the equation. B12 deficiency severe B12 deficiency can cause spinal cord issues that can look like MS. So outside of that, there is a trend towards people with MS having lower B12 levels. So the beauty of B12 is no one has ever been hurt by B12. Some people do get a nice energy boost with it. I don't think there's any harm in taking oral B12 over the counter. Certainly if your B12 levels are low, we might want to go to really low, we might want to go to an injectable route. Some people don't absorb B12 normally. So pernicious anemia is a condition where people really cannot absorb B12. So it doesn't matter how much you take by mouth, you're never going to get it in their system. You have to take it by injection. If you've had GI procedures, gastric bypass for weight loss, you may have issues with B12 absorption and have to look at doing it by injection. So yeah, I do think everyone should have their B12 levels checked if they haven't. Certainly if they're low, we're going to replace it. I think for all of us taking some on a daily basis, there's certainly no harm in doing that.
And Karen also has a follow-up question. Any suggestions for constant stiffness even when exercising?
So it probably would help for us to think about what's causing that stiffness. So is it spasticity or increased muscle tone from your MS, or is it a joint problem? So do you have a little bit of osteoarthritis? And so is that what the problem is? So I think if we could separate those two out, it might point you down different pathways. We have all kinds of treatments for MS-related spasticity. Your range of motion is going to be your first kind of level of treatment, making sure we've got that person in a really good stretching program, stretching before exercising, stretching after exercising. Maybe yoga is a big part of their exercise program because that's such a great stretching routine. And then kind of going up into potential medications after that. If it is more of a joint issue, we may need to look at modifying the exercise program so that we do lower impact exercises and maybe look at more aquatics type programs or or things that where we're not beating up the joints quite as much.
And we have two questions from Kanita. One is 90 milligrams a reasonable level if you aren't taking calcium, I guess, for vitamin D?
That 90 milligrams would be an odd dose.
Or NG, it's 90 NG/ml, sorry.
So what you really want to try to do is convert that over into units. So normally with vitamin D, we'll think about sort of 1,000 units, 2,000 units. I don't know what that would convert to right offhand. Maybe Casey or someone can do a little math behind the scenes for us and see what that would convert to. But again, with vitamin D, you can't really say that there is an ideal dose for all humans. Your ideal dose is whatever it takes to get you up into that desired range. Some people don't need any vitamin D, so their ideal dose would be none. Other people are going to need these big doses, 50, 100,000 units a week to get their vitamin D levels up to those desired ranges.
Okay, and the second portion of the question is, what about taking clementine?
So clemastine is
clemastine. Okay.
Yeah, so it's kind of gone dark on us. So there was a study out of UC San Francisco, gosh, it's almost 2 years now, that showed that it may have some neural repair properties. So the backstory is that University of California, San Francisco had a big grant from the National MS Society to look at drugs that are already FDA approved for something, to see if in the test tube they could show that those drugs promoted myelin repair. And they developed an assay called a micropillar array. So you could test thousands of drugs very quickly in the test tube. These were things that are already FDA approved for something else. So the beauty of that is you don't have to do human safety testing. You don't have to do any animal testing. If it worked in that test tube, you can jump right into a human trial. So clemastine looked good in the test tube. They then took it to 50 individuals with permanent visual loss from optic neuritis, treated all 50 of those individuals with 6 months of the clemastine, and they all 50 had some degree of visual recovery. So that was very exciting. I've not heard anything else, a follow-up study on that. Does that mean that it would promote remyelination in everyone with MS? We just don't know. Clemastine is the active ingredient in Tavist. It's an antihistamine. Now, I will say they used a very large dose at UC San Francisco. It was about 3 times more than you would typically take just if you had seasonal allergies. I will say we've done it. We've treated a number of people with it. I've had a small handful say that they felt like things might have gotten better. I've not been blown away with it yet. So at this point, if someone brings it up with us and they really would like to try it, I'm not opposed to it. I would warn people it can be very sedating because it is a big dose of the drug. So I would say stay tuned on that one. That's a huge area of research in MS, is repurposing old drugs to see if maybe just by luck they might remyelinate.
All right, let's see if anyone has any questions. Please make sure you submit through our chat feature, or if you'd like to raise your hand and ask a direct question, you're welcome to do that. Just select more. It's the icon with the 3 dots, and click the raise hand. I'll unmute you, and then a prompt's going to appear on your screen asking if you'll allow me to do that, and please select allow. Another question from chat comes from April. I've been having more issues talking for over a month now. I have lesions on my brain and waiting to see MS specialists. Will DMTs help?
So when you think about managing MS, I would encourage you to step back and say everything that we do in managing a person's MS, you can put into one of 3 treatment buckets. We're either treating acute attacks, that's going to usually be either waiting them out or giving steroid, we're treating symptoms, or we're using a DMT to change the course. If a DMT is doing exactly what it should be doing, it really should do 4 things for you. You should tolerate it. It should be a good fit for your lifestyle and you're not having side effects from it. It should hopefully prevent future relapses. It should prevent new MRI lesions, and it should prevent disability. What those drugs are not designed to do is get rid of symptoms you've already got. So that's not to say you can't get better, but it's really important that you go into a DMT with the right expectations. Think of that DMT as an insurance policy for the future. It's drawing a line in the sand and hopefully saying no more. We're not going any further. If you think about managing your speech issues right now, you're probably going to get more benefit from working with a speech language pathology to improve that. Sometimes just time also. So you can get better, but I wouldn't think of the DMT as necessarily being the tool that you want to use to get better.
Okay, we have another question from an email on DMTs. It looks like it's a two-part question. How do I choose the most effective DMT for myself when the two I'm considering were never in a head-to-head clinical trial?
Yeah, if you figure that one out, let me know, because we want the same thing. We would love to see everything thrown into one ginormous trial and everything head-to-head, but we don't have that. Typically, there are some head-to-head trials, but it's usually not with the ones that we would like to see. So you can give a general ranking. So we have 22 disease-modifying therapies. Some of those are overlap. They have very similar mechanisms of action, or maybe it's a generic form of a name brand. But in general, you can sort of grade drugs on how effective they are, how well tolerated they are, what their safety profile is. And there's no one right treatment for everybody. I think most people would agree that kind of the top of the food chain is going to be your infusible medication, things like natalizumab or Tysabri, ocrelizumab, Rituxan, Ocrevus and Rituxan, Lemtrada. And then it gets a little more difficult. So your what we call your S1P drugs, your Gilenya, Zeposia, Mayzent type drugs are probably right there. Mavenclad's probably right there underneath those. So just because something looks more effective on that flow chart doesn't necessarily mean that something below that couldn't be a winner for an individual. I have individuals who've been on platform therapies, our old interferons and glutamate or Copaxone, since the 1990s, and they're doing great with them. So even though something on paper looks like it might be more effective, for that individual, if you're doing well on whatever therapy you're on, you may not need to move to something else. So now, the challenge is, how do we pick, from that list? What you'll see is that different MS healthcare providers kind of fall into two camps. There are people who follow what we call an escalation therapy paradigm. They're going to pick something that's got a good safety profile, maybe not quite as effective as something above it. They're going to start that, and if you do well, great. If you have breakthrough symptoms, then they'll move you up the food chain to something else. The other paradigm is called induction therapy, and that would mean picking one of those more effective therapies from day one, realizing there could also be a little more risk associated with that. Every MS center has a bias one way or the other. So we're biased towards induction therapy. We think that picking a more effective therapy from day one is the way to go. But what I want has to match with what you want. So we have to talk about the risks of those medications and make sure that that fits with what's okay for you.
Okay, thank you for that. Let's see, we have a question from Cindy. Cindy, I'm gonna ask you to unmute and go ahead and ask your question to Dr. Thrower.
Hey, Dr. Thrower.
How are you?
I'm great, thank you. How are you?
Good.
Good. As you know, my brother passed away in December from COVID, and I'm having a terrible, terrible time dealing with it. Is there anything I can take to help? I am on Wellbutrin for the depression, but this is different.
So, there's an appropriate level of grief that we're all going to go through with a loss like that. And then the hard thing is, at what point is it too much grief? Are you, is it going on for long, or is it really affecting the way you function and your daily life? Is it so bad that a person would be thinking about harming themselves? So there's no, it's different for everybody. There are always more things that we can add. So Wellbutrin's a great antidepressant. Sometimes we put a little something with it to help it work even better, so that they kind of complement each other. If you make sure you've got a lot of family around you and that you're talking about it. There's sometimes, I think, a tendency for people after a loved one dies to say, oh, we better not talk about it because it's going to bother her or the person who's lost. I think that's I think talking about the person is the way that we remember them, we honor them, because I think the other way is just not very healthy. So we're here to help in any way we can. Yes, there's always more that we can add. And then we want to certainly put those counseling services out on the table too. One of the, COVID has made telehealth just seem like a normal thing. And not everything in the MS healthcare world fits with telehealth. It's hard to do physical therapy by telehealth. Counseling is a nice fit for telehealth. So that's, something that we can certainly look at.
Okay.
Yeah,
Thank you.
absolutely. Just let us know.
I will. Thank you so much.
Thank you, Cindy. Our next question we have is from April. April, if you would unmute and you can ask your question.
Yes, I just had a question. I was wondering, like I said, the last month I've been noticing more issues with my speech. If I talk slower, sometimes it's not as bad. And I've also been having more issues. Like yesterday, I done more cleaning, and I was actually like dragging my leg, and this has since December, it's been going progressive. I mean, just progressively downhill. So the DMTs won't stop the damage that's already started. It'll just keep more damage from start. Right.
So your DMT again is going to hopefully draw a line in the sand and say no more, because we're not going to get any worse than this. And then what we want to do is step back and say, okay, how do we work with the symptoms that you've got? So some of what you're describing sounds like you could have something called nerve fiber fatigue. So when you look at the areas of old myelin damage in the brain or spinal cord in a person with MS, that's the weak link in the electrical conduction chain. And so a lot of people with MS start their day, maybe their walking is here, and then as they do more through the day, it gets harder and harder and harder. Then they're dragging their feet, they're having a hard time with balance and strength. They go to bed, they rest, they cool off, they relax. The next morning, their batteries recharge, and they kind of go through that cycle again. So the important thing to know is that if a person does have nerve fiber fatigue, you're not hurting anything by pushing through the day. There are treatments that we can use to push back on that. There are medications, there's rehabilitation. One of the things we've shown through some of the research here at Shepherd is if we recondition someone, we push that line in the sand out, they don't hit that nerve fiber fatigue wall quite as quickly. So they're able to do more. They're able to tolerate more heat a little bit better because they're in better shape. Speech is complicated. So there's the motor part of speech, of how our tongue and lips and everything moves to form words. And then there's the cognitive part of speech. So a lot of times with individuals like yourself, we'll get a speech language pathologist involved to help us sort out, well, which is this? Could it be nerve fiber fatigue affecting your speech? So as the day goes on, your voice gets quieter or harder because you're just tiring. Or is it more of a motor issue, or is it word finding difficulty because of cognition? And when you think about the healthcare team at an MS center, I think the speech language pathologists probably wear more hats than just about anybody else. So they deal with swallowing issues, they deal with cognitive issues, and they deal with speech issues. So that would be a person we would probably want to get involved in your case.
All right. So going back to Kanita's question, Casey said that the vitamin D wasn't about dose, it was about her test result.
Ah, gotcha.
And
okay.
so her test result was 90 ng.
So in most labs, what they're going to say is that the lower limits of normal is about 30. And most labs will say anything over 80 is a little bit on the high side. So 90 is a little on the high side. It's certainly not run screaming from the room high. I've had people that were okay running them at 90 and just leaving them there. Depending upon her dose, she might want to talk to her healthcare team about maybe just lowering it a smidge, just to maybe bring you down into the 70 range. So again, it's a little bit high, but nothing horrific.
Okay, and we have time for about one more question, and we'll take the first one here. It's from Karen, who had another Karen. She read that CD20 B cell DMTs like Ocrevus help lessen cognitive impairment over time with primary progressive MS. Do you believe that's true?
So the Ocrevus is the only thing we have going for us in primary progressive MS. I think that the studies did show that it slows progression of disability, and the drug companies sometimes want to tease out different specific types of disability, like they'll focus on walking or cognition. In my mind, if you have something that works on disability, it should probably work across the board. I think that in a person who has cognitive issues, that Ocrevus should slow down that progression of cognitive dysfunction, just like it slows down the progression of gait issues, which are probably one of the bigger issues with primary progressive MS. So the quick answer is yes, I do believe that.
And she does have a follow-up question. Do you feel Ocrevus and
Kesimpta.
Yes. Thank
Yeah.
you. Do you feel they're the same?
So they have the same mechanism of action. So they're both anti-CD20 monoclonal antibodies. I've certainly used a lot more Ocrevus than I have Kesimpta. My gut feeling would be that if you did a head-to-head on those two, they should be pretty darn close to each other. It's going to be pretty easy to sort that out in the real world. We can follow CD19 counts. So it sometimes seems a little odd for people on one of these drugs that, it's an anti-CD20 drug, but we're usually following CD19. CD19 receptors and CD20 receptors travel together for the most part. They separate a little bit towards later B cell maturation, but usually you're doing the CD19 receptor to tell you what CD20 is doing. CD19 is a more commercially available test. So we can follow those things in a person on Ocrevus and a person on Kesimpta. What we want to see is that your CD19 count is 0 if you're on Ocrevus or Kesimpta. We want the rest of your immune function to be normal. We want your T cell subsets, which those drugs hopefully don't affect. We want those to be normal, and we would like your antibody levels, your IgG levels to be normal. So we can dial those things in with Ocrevus or Kesimpta and know that the drug is doing what it's supposed to do, but not doing more than it's supposed to do.
All right. Well, thank you, Dr. Thrower. That's really all the time we have for now. And if you missed any part of this teleconference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page, as well as our YouTube page. You can follow us on MS Focus on Facebook, Twitter, and Instagram for times and access information. Our next teleconference with Dr. Thrower is going to be Tuesday, April 13th at 3:30 Eastern Time, and he's going to be speaking with us about men's health and MS. So our sincere thanks to all our sponsors, the attendees, for your participation, and especially to Dr. Thrower. Do you have any final thoughts?
Oh, just again, thank you so much to you, Chris, to everyone else behind the scenes there, Casey, Deb, all of you folks. I know you guys, your lives have been changed quite a bit through all this, the COVID, craziness, and you guys have not missed a beat whatsoever. You've been delivering services in a way that we all very much appreciate. So thank you to everyone who joined in with us.